Maria, a 68-year-old woman, was admitted to a respiratory ward with an acute exacerbation of chronic obstructive pulmonary disease (COPD). COPD is a progressive condition marked by persistent airflow limitation and symptoms such as dyspnea, cough, and sputum production. Exacerbations often lead to hospitalization and associated with increased mortality. Maria migrated to Australia 10 years ago and speaks little English, relying on family for interpretation. Her family questions the need for admission, indicating limited understanding of COPD severity and risk of early discharge. This scenario highlights the issues of chronic disease management, communication barriers, health literacies, and cultural expectations. Physical, emotional, and social impacts. Physically, COPD causes a shortness of breath, fatigue, and reduced exercise tolerance, limiting daily activities and quality of life. Frequent exacerbations accelerate lung decline and increase hospitalization risk, making prevention and early detection essential. Maria likely used multiple medications, including bronchodilators and inhaler corticosteroids, which increase complexity and the risk of incorrect inhaler technique, a factor linked to poor outcomes. Emotionally, Maria may feel anxious and vulnerable. Acute breathlessness can trigger panic, especially in older adults with limited disease understanding. Hospitalization in an unfamiliar environment where she cannot communicate easily may increase distress and reinforce her desire to return home. Language barriers and low health literacy reduce engagement in self-management and understanding of treatment plans. Socially, Maria's experience reflects her identity as an older migrant with strong family ties. Reliance on family interpreters can limit her voice, as relatives may filter information. Cultural norms may prioritize home care, making hospitalization seem intrusive or unnecessary. Expected outcomes if nothing changes are made. If Maria's current trajectory continues without significant changes to her understanding or support, several issues are likely. Clinically, a lack of COPD knowledge and poor self-management may result in recurrent exacerbations, frequent emergency presentations, and hospital readmissions. Each acute episode can further reduce baseline lung function and functional capacity, contributing to increasing physical decline and dependence over time. Psychologically, repeated deterioration without adequate support may increase Maria's anxiety and diminish her trust in health services. Her family may experience stress and caregiver burden as they attempt to manage episodes at home without clear guidance. If communication barriers and cultural misunderstandings remain unaddressed, Maria and her family may become more reluctant to seek help early, instead representing late during exacerbation, which further worsens the outcome. Digital health strategies. A nurse-led telehealth model using home telemonitoring offers a practical strategy for managing COPD at home. Telehealth, the use of telecommunications to deliver care remotely, is widely promoted in Australia to improve chronic disease management and access. In this model, Maria would receive a home kit, such as a Bluetooth pulse oximeter and a tablet with COPD apps. Daily symptom load, inhaler use, and oxygen saturation will be securely transmitted to a clinical dashboard for nurse review. Nurses respond to alert and conduct scheduled video or phone consultations. Evidence show telehealth and remote monitoring can support self-management, enable early detection of deterioration, and reduce hospital admissions. Nurse-led virtual intervention improve clinical indicator adherence and parent satisfaction when combined with education and tailored feedback. These benefits align with guidelines to reduce preventable hospitalizations and support home-based COPD care. Telehealth enhance clinical safety through early identification of exacerbation, timely medication adjustment, and action plan reinforcement. Educational resources in Maria preferred language and automated reminders promote adherence. Socially, family involvement in video calls and interpreter access ensure cultural sensitivity and enforce consent. This approach respects Maria autonomy while supporting shared understanding and sustainable home care. Challenges and nursing strategies. Despite its potential, implementing telehealth and telemonitoring with Maria and her family raised several challenges that require thoughtful nursing responses. The first challenge is digital literacy and technology access. Older adults, particularly those with migrant backgrounds and limited English, may have less experience with smartphones, tablets, or apps, and may face sensory or cognitive barriers that make technology use. Households may lack reliable internet access or suitable devices. If these challenges are not addressed, digital health tools could unintentionally increase health inequalities and cause frustration for users. To address this, the nurse should conduct a structured assessment of Maria and her family access to technology, internet connectivity, and comfort with digital tools as a part of discharge planning. Identifying a family member who can assist Maria with device use while respecting her decision-making role is a practical strategy. The nurse can provide hand-on training using demonstration, simple language, and teach back to ensure that Maria and her family can operate the pulse oximeter and apps correctly. Creating a one-page images guide with screenshot and minimal text offers a reminder. Where available, the nurse can link Maria with hospital or community programs that loan equipment or provide digital literacy support, acknowledging equity consideration. A second challenge related to language, cultural safety, and communication. Many telehealth platforms and educational resources are designed in English and may not fully meet the needs of people who speak other languages. Reliance on family members and interpreters can compromise the accuracy of information and may inhibit Maria from expressing sensitive concerns or preferences that differ from those of her relatives. Nursing strategies here include routinely using professional interpreters for key telehealth interactions, such as explaining the telehealth program, obtaining content, discussing action plan, and recording to deterioration. The nurse should check Maria's permission for family members to be present in calls and direct questions to Maria with interpretation support to ensure her voice is central. Adopting a cultural safe communication style by exploring Maria's beliefs about illness and hospital care. acknowledging the importance of family being sensitive to possible stigma, further support trust. A third challenge is critical safety and clinician workload. Telemonitoring generates substantial data that must be reviewed and acted promptly, otherwise patient safety may be compromised. At the same time, nurses may experience increased workload if telemonitoring tasks are added with their adjustment to staffing or workloads. To mitigate this issue, the nurse should work with the multidisciplinary team to develop clear protocols for telemonitoring. This includes setting evidence-informed thresholds for oxygen saturation and symptom changes that trigger the alerts, defining expected response times, and specifying escalation pathways to GPs or emergency services. Integrating telehealth documentation into existing electronic medical records can reduce duplication and streamline workflow. Clarifying roles, just as which staff member reviews daily data and who contacts patients, supports efficient and safe practice. Aligning telemonitoring alerts with Maria written COPD action plan ensures that both she and her family know what to do when certain symptoms or readings occur. A fourth challenge involves engagement, adherence, and privacy engagement with routine data entry, and health monitoring tends to diminish over time when patients perceive limited benefits or when associated tasks are experienced as complex. Maria or her family may also have concerns about data security, access, and potential misuse of personal health information, which can affect their willingness to participate fully in telehealth. To address engagement, the nurse can collaborate with Maria and her family to set meaningful patient-centered goals, such as reducing short of breath during daily activities or avoiding hospital readmission, which telehealth monitoring can help support. Providing regular feedback during telehealth sessions, such as showing simple graphs of symptoms or oxygen change, demonstrates that the data is used and reinforces the benefits of ongoing participation. To address privacy, the nurse should explain in clear and language appropriate terms that information is collected, who can access it, how it is stored, and under what circumstances it might be shared in line with legal and organizational requirements. Documenting Maria's informed consent to telehealth and revisiting this is essential for ethical practice. Digital health has the potential to reduce access barriers, but can also exacerbate inequities if programs are not designed for appropriate groups. For an older migrant woman with limited English, the nurse has an advocacy role in ensuring that telehealth services are inclusive, accessible, and responsive. Dissemination of outcomes on social media. If a nurse led telehealth program for patients like Maria demonstrate positive outcomes such as reduced hospital readmissions, improved self-management, or higher patient satisfaction, sharing this learning more broadly can promote innovation and best practice across healthcare settings. Social media offer a powerful platform for dissemination, enabling rapid communication with both professional peers and the public. However, nurses must adhere to professional standard and organizational policies governing online engagement. Australian regulatory guidance stresses that health professionals must maintain confidentiality, avoid boasting identifiable patient information without valid consent, and ensure that any publicly shared content is accurate and not misleading. Nursing organizations include Australian Nursing and Midwifery Federation, ANMF, similarly caution against sharing material that could enable patient re-identification, even unintentionally. These principles are critical to uphold trust and protect patient privacy. For consumer health education, health services can use official social media channels to share general de-identified information about COPD, self-management strategy, and telehealth benefits. Both might highlight that nurse-led telemonitoring supports early recognition of exacerbation, improved inhaler technique, and safe home-based care without references specific patient. Visual content such as infographics or short video can illustrate warning signs of exacerbation. The importance of action plan and how telehealth appointments work. Linking these posts to reputable resources, including national COPD guidelines or Lungs Health organizations, enhance credibility. To ensure inclusivity, multilingual content should be developed to reach culturally and diverse communities like Myriad. This approach not only improves accessibility but also demonstrates cultural responsiveness in health communication. For patient education, some tips for telehealth program can be shared, such as how to prepare for COPD telehealth visit or 5 days daily symptom tracking can help you stay well with COPD. These posts should avoid clinical images, dates, or details that could identify individuals. Clinicians must not provide personalized clinical advice via public comments. Instead, patients should be directed to appropriate care pathways. Clear disclaimer can reinforce that social media content is for general education only. For professional practice, nurses may share reflection or quality improvement insights on professional networking platforms or closed clinical forums. Such posts should focus on system-level learning, service design, and evidence-based practice rather than individual patient stories. On potentially identifying details such as names, ages, specific words, or distinct descriptor must be omitted. By following this principle, nurses can leverage social media to disseminate value insights from digital health initiatives while safeguarding privacy, confidentiality, and professional integrity. Responsible use of social media ensures that innovation is shared widely without compromising ethical standards, ultimately supporting safer and more equitable care. And this is the key takeaways and conclusion. Thank you for listening. This is the references.